In December 2024, the FDA approved Tislelizumab with chemotherapy for PD-L1 positive advanced metastatic gastric and gastroesophageal junction adenocarcinoma, and this was based on the RATIONALE-305 trial. RATIONALE-305 was a randomized placebo-controlled trial that evaluated chemotherapy with either placebo or the PD-1 inhibitor tislelizumab. Tislelizumab is a PD-1 inhibitor given every 3 weeks, and over 1,000 patients were randomized. This trial demonstrated an improvement in overall survival and progression-free survival in the tislelizumab arm. This really reinforced what we've learned from CheckMate 649, which was the addition of nivolumab to chemotherapy, and KEYNOTE-859, which was the addition of pembrolizumab to chemotherapy, reinforcing that PD-1 inhibitors have an important survival benefit in this population. If you look, I think one thing I think about when doing cross-trial comparison, which we always have a big caveat about, is really taking into account the control groups. Because one thing you'll notice from the RATIONALE-305 study is that the tislelizumab group, the PD-1 inhibitor group, had a median overall survival of 17 months compared to 12.6 months, which numerically is slightly longer than was seen in CheckMate 649 or KEYNOTE-859. However, looking at the hazard ratio of these groups, you can see it was very similar. Hazard ratio of 0.74 in RATIONALE-305 compared to 0.71 in CheckMate 649. Looking at the PD-L1 high subgroups, and when looking at all treated patients on the study, the hazard ratio is 0.8 in both RATIONALE-305 as well as CheckMate 649, and 0.78 in KEYNOTE-859. Similarly with the progression-free survival numbers, 0.68 in PD-L1 high patients, and 0.77 and 0.78 respectively in all comers. One important distinction, though, about this study compared to the other studies we mentioned is how PD-L1 was measured. Now, of course, in gastroesophageal adenocarcinoma, both junctional tumors and gastric tumors, we use CPS, or combined positive score. This is different from other tumor types such as lung, which use TPS, or tumor proportion scores. The main difference being that we know in esophagus and stomach adenocarcinoma, it's not just the PD-L1 expression on the tumor itself, but also the surrounding stroma, the immune cells, that really has an important benefit. And so CPS, combined positive score, requires the pathologist to sit there and count 100 cells to determine what percentage of those cells are positive. So the score is out of 100. It's a proportion. It's a percentage. And the relative contribution takes into account the stroma and immune cells, as well as the tumor cells themselves. TAP, or tumor area proportion, is very, very similar, but more spatial as opposed to actually counting all the cells. What Rationale did is that by using TAP, they actually showed in one of their subgroups and exploratory analyses that CPS and TAP were similarly predictive of outcomes to their PD-1 inhibitor, tislelizumab. Based on this study, the FDA approved tislelizumab in addition to chemotherapy in patients with PD-L1 positive tumors. Since PD-1 inhibitors are already in the clinic, for a lot of us, this may not directly change practice because we already have nivolumab and pembrolizumab at our disposal. But what this does do is not only add a third PD-1 inhibitor, tislelizumab, to our armamentarium of potential therapeutic agents, but it really adds to the wealth of growing data showing that immunotherapy has a really important role in this disease type, number one, and number two, that the benefit is really enriched in those with PD-L1 positive and PD-L1 high expressing tumors. In addition to the efficacy, we saw very similar adverse events and safety profile from this study compared to the other two studies we just talked about. We know that fluoropyrimidine and platinum-based doublet chemotherapy is the backbone most commonly Folfox in these patients, especially given swallowing issues with pills that when using capecitabine, although Capox is also an option, especially in the every 3-week regimens. Beyond so that chemotherapy represents or chemotherapy accounts for the majority of toxicity in our patients. Beyond that, PD-1 inhibition has a very reliable safety profile regarding the immune-related adverse events, and tislelizumab was very similar to what we saw in the CheckMate study with nivolumab and the Keynote study with pembrolizumab, where the majority of patients have manageable immune-related side adverse events, and it's really a smaller proportion of patients that have higher grade 3 or grade 4 immune-related adverse events. However, these can be very dangerous, and so we have to be incredibly diligent about counseling our patients to come forward with any symptoms so that we can be sure to think of these adverse events, because they can sometimes be a little bit more subtle, specifically thinking about pneumonitis, hepatitis, and colitis, different GI inflammations that can be quite debilitating. And it's really important to engage our multidisciplinary experts, our gastroenterologists, pulmonologists, hepatologists, with this, because in addition to stopping the PD-1 inhibitor, starting immune suppression with steroids to calm down the inflammation caused by the PD-1 inhibition, there are other anti-inflammatory agents that can sometimes be helpful, infliximab in colitis-related issues, and so forth. And so RATIONALE-305 added to our growing knowledge showing that upfront PD-1 inhibition is beneficial for the large majority of patients. We saw in RATIONALE-305, similar to CheckMate 649, about half, 45% in this case, or 55%, excuse me, were PD-L1 CPS TAP5 or CPS 5 or greater, and close to 80% are PD-L1 positive. So that with based on this study, the FDA approved the use of this drug, and it's now available for our patients.